Nursing 345, Pain Assessment, the fifth vital sign. On this first slide are the objectives for this week. They are: describe the 8 characteristics included in the summary of each patient symptom, relate developmental care during a health history for a child or older adult, discuss the use of inspection, palpation, percussion, and auscultation as a physical exam technique, understand the use of blood pressure cuff of improper size to the possible findings that may be obtained, list the information considered in each of the 4 areas of the general survey, which include physical appearance, body structure, mobility, and behavior, assess and acknowledge the different types of pain, recognize developmental care as well as cross-cultural and gender considerations regarding pain, list the steps of a complete health assessment, explain the differences between a focus and a complete health assessment, describe the techniques needed to perform a complete health history and physical exam, document the results of the examination, and identify the tools needed to complete the physical examination. So first, we're going to talk about nociception. Pain is a highly complex and subjective experience that originates from the central nervous system or peripheral nervous system, or both. Pain develops by nociceptive and neuropathic processing. Nociceptive develops when functioning. Pain develops when functioning and intact nerve fibers in the peripheral and central nervous system are stimulated. It starts outside the nervous system from actual or potential tissue damage. Nociception occurs in 4 phases. The 4 phases are transduction, transmission, perception, and modulation, which are explained on your slide. This pain typically is predictable and time limited based on the extent of the injury. Neuropathic pain does not adhere to typical and predictable phases. It implies an abnormal processing of the pain message as a result of injury of the nerve fibers. It is sustained on a neurochemical level. Physical pain sources are based on their origin. Visceral pain originates from larger internal organs such as the stomach, intestines, and gallbladder, and pancreas. Somatic pain originates from musculoskeletal tissues or the body surface. Deep somatic pain comes from sources such as blood vessels, joints, tendons, muscles, and bone. Cutaneous pain is derived from the skin and subcutaneous tissues. Referred pain is felt at a particular site but originates from another location. Pain can also be classified by its duration. Acute pain is short-term and self-limiting. It often follows a predictable track and dissipates after the injury heals. Acute pain has a self-protective purpose. It warns of an actual or threatened tissue damage. Chronic or persistent pain continues for 6 months or longer. It results from abnormal processing by pain fibers from peripheral or central sites and does not stop when the injury heals. The level of pain intensity does not reflect the physical findings. Breakthrough pain is a transient spike in pain level in an otherwise controlled pain syndrome or the result of an incident or episodic pain event. Developmental care related to pain includes these points. Infants have the same capacity for pain as adults, but are at high risk for undertreatment of pain because they are nonverbal. Preterm infants lack inhibitory neurotransmitters and are more sensitive to painful stimuli. Although pain is common in older adults, it is not a normal process of aging. Pain indicates pathology or injury and should be investigated. Gender care related to pain includes these points. Genetic differences between men and women may account for differences in pain perception. Traditionally, men have been raised to be more stoic about pain, and more affective or emotional displays of pain are acceptable for women. With recent findings from the Human Genome Project, genetic differences between both sexes may account for differences in pain perception. Cross-cultural care. Related to pain includes the following: comparing pain treatment for individuals of color, for example, African Americans or Hispanics, with standard treatment for white individuals with similar injuries or diseases. Because most research is conducted on racial differences in pain has focused on disparity in management of pain for various races. Various studies describe how African American and Hispanic patients are often prescribed and administered less analgesic therapy than white patients, although most of these differences are small. So the initial pain assessment questions are listed on the slide. The subjective report, you have to remember, the subjective report is the most reliable indicator of pain. On the initial pain assessment, the clinician should ask questions about pain and discomfort, location of pain, whether the pain limits the patient's function or activities, and how the patient usually reacts when in pain. Pain is multidimensional in scope, encompassing physical, affective, and functional domains. Choose a pain assessment tool based on its purpose, the time involved in administration, and the patient's ability to comprehend and complete the tool. Use an overall pain assessment tool such as initial pain assessment or the brief pain inventory to assess chronic pain or problematic acute pain. I'm sure everyone is familiar with the pain assessment tools. You should use a pain rating scale to evaluate pain severity. A numeric scale is used for adults and older children. Pediatric scales such as the Oucher scale and the FACES pain rating scale are used for young children. Older adults may respond best to a verbal descriptive scale. Assess the patient's joints, muscles, skin, and abdomen to detect injuries or other signs of painful disorders. When a person cannot verbally communicate the pain, look for nonverbal behaviors of pain such as guarding, grimacing, moaning, agitation, restlessness, stillness, diaphoresis, or vital sign changes. Keep in mind that individuals react to painful stimuli very differently. Chronic pain behaviors have even more variability than acute pain behaviors. Behaviors associated with chronic pain include bracing, rubbing, sighing, and change in appetite. This last slide, it shows examples of subjective and objective charting. So this is how a nurse's note would look like, what a nurse's note would look like regarding pain. So for subjective, it would read, starting within the past 2 weeks, states having severe epigastric pain within a half hour of eating greasy, fatty foods. Pain is stabbing and squeezing in nature with radiation to the right shoulder blade. Rates pain as a 10 on a scale or on a 0 to 10 scale. Nausea accompanies pain. Takes antacids with minimal relief. Pain diminishes after bringing knees to chest and not moving for a 1 hour period. Objective data would include patient is diaphoretic, grimacing, and having difficulty concentrating. Breathless during history, arms guarding upper abdominal area, abdomen distended, severe tenderness noted on left upper quadrant, and epigastric palpation. Bowel sounds hyperactive in all 4 quadrants.